We are the resistance to the current healthcare system. We really think there's a better way to provide primary care. And if we actually focus on primary care, then there's that old saying, an ounce of prevention is worth a pound of cure.
Without any further ado, I want to tell you, the other day, I was on Facebook, surprise of all surprises, and I received a friend request from someone that had a few other mutual friends, and so I accepted it, and it was Dr. Suddeth. And then from there, I received a request to like their business, his business. And I started poking around, and I started looking at what this business was about, and I got really excited. And I got excited because we always complain, and we're always trying to, we find problems, but I think that we found a solution in this, if I'm not wrong. And I say that because, you know, when we talk about health care, we're talking about health care, and other people are talking about insurance. And those are two completely different things. And our health care should be something that is between us and our primary care physician and our everyday, day-to-day things. And insurance should only be needed in the event of a catastrophic event or an emergency. And so I started poking around on their website and seeing what they were about and how they work and everything. And I started thinking about all the possibilities that, you know, the way that this business model works, how it could help and it could benefit so many people. And so I reached out to him on Facebook, and Dr. Street responded. And so I'm going to read for you his bio off of the website, and then I'm going to bring him up and let him tell you about the business that he and Dr. Suddeth have. Dr. Street obtained his Bachelor of Science from the University of Oklahoma, where he also met his wife, Liz. He earned his Doctor of Osteopathy from A.T. Still University, formerly known as Kirksville College of Osteopathic Medicine in Kirksville, Missouri. He completed his family medicine residency at Wesley Family Medicine, affiliated with the University of Kansas, Wichita Center for Graduate Medical Education. Dr. Street also has extensive experience working as a hospital doctor in both Kansas and in Oklahoma. Dr. Street and his wife Liz have twin boys, Madden and Asher, and a little girl, McKenna, who definitely runs the show with her gap-toothed smile. The whole gang has superhero alter egos who come out for epic trampoline battles, end-of-movie dance parties, along with trips to the park, aquarium, and children's botanic gardens are family favorites. Fall Saturdays are devoted to Sooner football. Well, of course. On Sundays, the Streets love attending Olivet Baptist Church, where they enjoy fellowshipping and receiving God's Word with family and friends. So please join me in welcoming Dr. Street.
Is it okay if I move this over here?
You can move it wherever you like. You're the boss now.
All right, that's what I like to hear.
Take advantage of it while your daughter's not here.
Yeah. Or my wife.
Or your wife.
Yeah. So hopefully I don't drop this, because this is not cheap, but I'm going to use this just so I can scroll through stuff. So sorry if I don't hold this up here, but so I'm Dr. Street. My partner's Dr. Suddeth. These are our families. And so we run Remedy Health Direct Primary Care. The reason it's called Remedy, a couple things. People are looking for a remedy to their ailments, but also looking for a remedy for the broken healthcare system. Okay? So that's us. That's the sign in front of our office. We're located at 101st and 5014 East 101st Street, Suite 200. So it's 101st and Yale, the southeast corner, just behind the Prosperity Bank. It's kind of hard to find, actually. But so when we talk about healthcare, we talk about the 3 Ps. Okay, the person seeking healthcare, the provider, and then the payer. All right, makes sense. The way the system works is the person pays a payer a monthly fee, you know, your insurance premium every month, and then you go seek out a provider, and you make an appointment with your provider, you go see them, they take care of you, you go on your way, you paid your copay, whatever. Well, then the provider submits a claim to the payer and waits about 3 or 4 months to get reimbursed. And then, lo and behold, you get a surprise bill later saying you haven't met your deductible and you owe us or the provider whatever cost was associated with that. So that's the current system, and we'll talk about how that's a little bit different in our practice here in a bit. So this is just us examining some statistics here. So when we look at national health expenditures per capita, this slide is a little bit old, so I apologize for that. But you can see in 2012 is about $9,000 per person, and they kind of projected up into 2021 that it's going to be over $14,000. I don't know about you, but that just doesn't seem very sustainable. And I can tell you that there are practices that have been doing exactly what we've been doing for. I actually worked with one of the thought leaders, Dr. Josh Umber. He works for Atlas MD out of Wichita, Kansas. But he's been doing this in Wichita for 10 years. And his prices haven't changed in 10 years. So I think just looking at that and looking at these projections, if you can actually keep costs flat, that seems to make more sense, right? So again, another old slide. This talks about the American GDP and the cost of everything, taking into account Medicare, Social Security, Medicaid, and then of course the interest with our national debt, which is ballooning. That's a whole different subject. So this says that, that we're around 18.5%. Well, that was true in about 2011. We're actually around 20% of our GDP for healthcare, and that's more than double any other big nation in the world. And you'll see later, actually on the next slide, why that's not such a great thing for America. But this is projected again by 2032, entitlements plus interest consumes all tax revenues. It's just not sustainable. So we have to come up with a solution. And I tell people all the time, for healthcare in particular, if you're gonna let a hospital system, an insurance company, or the government figure it out, we're all screwed. Okay? I mean, that's just reality. So that's why we're here. So when we look at healthcare outcomes, again, you're looking at developed nations. They took, the top 11, and we are at the bottom. Pretty sad. We spend twice as much money, but we're the worst. Doesn't make any sense. So we got to figure it out. Then you look at the state of Oklahoma. In a country that's not doing very well, we're 47th. It's horrible. Well, education. You can throw all these things at roads. We have more tolls than everybody, but our roads are still horrible. But anyway, we're not doing very well as a state, right? So we have to figure out some kind of solution, and we're going to fight for it. So these are just some facts. Again, the top one is we spend twice as much on healthcare. Chronic diseases, they consume 86% of our dollars, and it affects 50% of people. In fact, about 50% of all healthcare dollars are spent in the last 1 year of people's lives. And so if you look at the UK, they do different things. They have, if your BMI is over like 30, you can't have surgery. And they kind of create death panels, like, you're at the end. We're not going to spend any more money on you. And that wouldn't fly in America because we're a little entitled, and we want it now. But you can't keep doing what we're doing. It's just not going to be sustainable. The other thing is, social, environmental, and economic factors plays a role in about 50% of our healthcare determinants. So what determines our health? 50% social, environmental, and economic factors. Yet we spend 97% of our money not on these. We spend 3% on this. And then, of course, you have, structural barriers. That's government, insurance, et cetera. So this is the convoluted healthcare system that we're in. Yeah, it looks very simple, right? Yeah, it should be a lot more simple than that. So even though this is what we're dealing with, really what we should be worrying about is the patient experience. Dr. Street. So this is the healthcare system. You have a patient, and then there's tons of things involved here. And then over here's your doctor. So the insurance is basically directing where your money is going, what lab you can have, what x-rays you can have, what medications you can have, what subspecialists you can see. So they kind of control everything, and I have a slide a little bit later that kind of expounds on that a little bit. But this is just kind of the fallacy of prices being high. You know, why is healthcare so high, right? Well, healthcare is so high that we ended up having to, we have to pay a third party because they're going to help us keep the cost down, right? We pay a third party. They're just going to, hey, but that's what we do, right? That's what they tell us. So you pay a third party, and how do they do it? Well, they restrict the networks. Well, you can't go see the doctor that you want to or what you need. So we can't have you go see these other people because, again, it's too expensive. It's going to cost so much money. And then they mandate algorithms. You have to do, a chest x-ray and an echo rather than just going and getting the CT that you need. You have to spend this extra money up front instead of going and getting the test that you need, because they want to make sure that since you went to medical school and they know what's better, that, we're not just wasting dollars, because that's what we love to do. Then they create restrictive formularies. So, you can't have this medication, even though it's controlled your blood pressure for 5 years, we're going to have to put you on something different because that's not in our formulary. But now it gets better. Now we have to create an ACO, an accountable care organization. It's going to save lots of money. You're just going to get this conglomerate of people, and you can only stay within that little system, and if you go outside of it, you're really going to be screwed. And then, of course, with these ACOs, they say, well, now, since the doctors really don't know what they're doing, we're going to set these metrics and make sure that they're doing exactly what we want them to do, and that they're hitting these little goals. That way that they can get paid, because we have a lot of control when people leave our office. I don't know. So then they also control your practice with the prior authorization. I'm sure you guys have all heard of those. You can't have this medication. You got to get a prior authorization because, again, the doctor doesn't know, and we need to do XYZ test prior to us doing that. Again, that's another way for them to, quote unquote, control cost. But as you can see, each of these adds a layer to the picture, and you have to hire people to do all of these things. And everybody has their hand out, and the more hands you have out, the more you pay. Here it is. Third parties add staff, right? You have to have insurance companies that have, their coders, their billers, the people that deny claims, the people that, deal with resubmitted claims, et cetera. And then the doctors have to add staff because we have to have people to resubmit the claims because, you want to get paid for your work just like everybody else. And essentially, the prices become high. So this is also a look at the primary care system as it stands. The patient is over here on your left, and they basically send their money two ways. If you go to the top, there's the nice building on the right. That's the government. We're sending money to the government in taxes, et cetera. And then you have the middle guy in the blue suit. That's your insurance agent. That's your insurance guy. You're sending money to the insurance guy. Well, money from the government floats over to insurance to help cover cost. And in the meantime, the patient is sitting next to the doctor, but look where the doctor's looking. He's looking at the insurance guy and the government. He said, hey, they're paying me. I'm going to do what they tell me to do because I want to make sure I get paid. I'll jump through whatever hoop they need to or want me to do so I can get paid. So this slide is basically it's going to hopefully hit home the fallacy of what good insurance is. I hear this all the time, that I have good insurance and all these things. And so part of our model is, let's look at what you spend. Let's look at the total expenses and see how good it really is, okay? So we're going to we'll just say a guy's named Bob, okay? This data is actually from the state of Michigan, and it's from 2017. So what's good insurance? Whoops. Sorry, I didn't mean to go forward yet. It's frozen. Okay. So this is actually the Affordable Care Act Gold Plan. We have the gold and the bronze, okay? So for this particular individual, if you look, the kind of grayish is actually his insurance premium over the year, okay? So for the gold plan, it's gonna cost this guy $18,000. So that's over $1,500 a month. And he has a nice deductible, $500. Man, that's a great insurance. His total out-of-pocket cost is $5,500 though, based on his insurance. And then if you look at the bronze plan, you have a higher deductible of $7,350, but your premium is $9,493. Okay. So even that, we tell people, hey, you have the worst year of your life. Well, let's say you don't see the doctor at all. With the gold plan, you're guaranteed to spend $18,000 before you get any care. With the bronze, you're guaranteed to spend $9,500 without any care. And let's say you have the worst year of your life. You max out, you use your $500 deductible and use your $5,500 out of pocket. Well, you're well over close to $24,000. Okay? And you look at the bronze plan, even if you had the worst year of your life, even with a higher deductible, you're looking at spending $17,000. So you've already saved $8,000 just compared to the gold plan. Well, how does that make sense? Right? You have good insurance, that $500 deductible. You're paying it all up front. So we're going to kind of look at this. This is actually kind of comparing plans here. Again, we have kind of the gold plan. We have that bronze plan, and then we have a couple of different things. So there are some health sharing ministries out there, Liberty, Sedera, Medishare. They kind of act like insurance in that you have a monthly giving and you have a sharing expense every month. The one thing that they can do, since they're not really mandated by the insurance commission, is they can actually hold pre-existing conditions against patients. So for some of those, I think they say is about 3 years. So if you've been on medication for a pre-existing condition for, within the last 3 years, they can hold that against you. But what they also do is on families, I think it's over 3, if I'm not mistaken, the price is the same. So if you add a 4th or a 5th or 6th, it doesn't cost you any extra money. So this middle graph is basically looking at one of the healthcare sharing ministries. It's still kind of expensive, but it is more affordable. You start kind of looking at other stuff. The one on the far right is like short-term limited duration insurance. That's the old, the bad insurance that the Obamacare got rid of. That was, this really high deductible plan for people that are in general pretty healthy, and they say, you know what, I'm fine with a $10,000 deductible. I don't ever get sick, and I'm going to use it like I use car insurance. If I get in an accident, that's why I have car insurance. I don't use car insurance to swipe at Quick Trip to fill up the gas tank or change my brakes or get tires or any of those things. So the whole purpose is we don't really need to insure primary care. We should make primary care affordable. A lot of people, talk about healthcare is so expensive, it's a right, it's whatever. It can be a right, okay, but primary care still needs to be affordable. And in the current system, it's not. So I was reading an article about 6 weeks ago, and they talked about insurance premiums. How much of your premium actually goes towards primary care? It's about 23%. And if you look at really what primary care physicians get reimbursed and whatnot, it's way less than 23%. So there's a lot of cream on there that somebody's putting in their pocket. So we're here to kind of shed the light a little bit. So this is just pointing out that, yeah, you're going to spend a lot of money with the gold plan. And then it breaks it down per week. The difference between the one on the far right is actually, so the 3 on the right are healthcare sharing ministry with direct primary care. And then the bottom one is like a limited duration insurance with direct primary care. And we'll talk about pricing. Our prices are, the average for direct primary care across the board, it varies depending on location. So we'll talk about that. So this is just a little cartoon that I think really portrays what we're dealing with and what we're trying to fix. So this brings us to our practice. I'll talk about our practice and talk about direct primary care in general. we are the resistance to the current healthcare system. We really think that there's a better way to provide primary care. And if we actually focus on primary care, then there's that old saying, an ounce of prevention is worth a pound of cure. We can save so much money. And as I stated before, 50% of healthcare determinants are lifestyle choices, social determinants. And if we just let people do whatever the heck they want to and try to pay for it on the back end, which is what we're doing now, it balloons the expense, and it's just not going to be sustainable. And if it's not, I don't want to be here. So direct primary care, this is actually defined by an Oklahoma statute here. So we have a buddy who's been doing direct primary care in Edmond, Jeff Davenport, and he actually helped draft legislation to actually recognize direct primary care in the state of Oklahoma. So basically, it's the provider agrees to provide primary care services to the individual patient for an agreed to fee over an agreed period of time. Okay? So for us, it's a monthly fee. Services, cost. Very simple. We want to be very transparent. That's the other thing. If they can't tell you what things cost,
we get that.
there's, and I know Trump's trying to do stuff. They already, they made hospitals put their pricing as of January 1 on the internet. Those prices don't mean anything. They can put whatever they want on there, which we'll get to.
So to follow up on that, when you go into have your car worked on, they have to give you an estimate. And then any changes to that have to be reauthorized by you before they do any work. Why don't we have that in medicine? Because isn't it the same basic idea? We've got a service, a cost, and we can see those prices.
That's an excellent question, but I will say, being a physician, there are certain times where you don't have time to think about what the cost is. You just do what you do to try to save somebody's life, Now, in primary care, you can probably do that. And honestly, in our clinic, I can tell you how much my lab is. I can tell you how much my medication is.
That's what I was going to mention, is that when you go on the website, he's got lab prices, he's got medication prices, they've got, if you need to have an x-ray. I just paid $500 for an x-ray with my really good insurance.
Yeah, you can
That
get it
was
for
my out-of-pocket.
$67 to $70 here locally.
If I'd have paid
If you just
cash,
pay
that's
cash.
what it would have been.
And so
And do you go out and make those contracts with other providers?
we do for some things. Interestingly enough, here in Tulsa, there are some independent standalone imaging facilities that already have cash pricing. The hardest part is people are still stuck in this, I have to use my insurance. And usually when I have patients have insurance, I have patients that don't have insurance. Often the people that have insurance always tell me they want to use their insurance first when they go get imaging or lab, and that's the only time they'll tell me, because the second time they say, I don't want to do that again because it cost me $500. And so they kind of learn real fast. I just say, go ahead, do it, figure it out yourself, It's just like a parent, telling your kid, hey, don't do that. They have to figure it out for themselves sometimes. So I will talk about some prices here in a little bit. And it's obviously not an extensive list, but we put that stuff on our website primarily because it should be transparent. You should know what it's going to cost. You don't go to a restaurant and order something and then say, here's my copay, and then get home later and 3 months later get a bill, and then you go, oh my gosh, I didn't know that steak was $120. I wouldn't have got that steak if that was the case, right? So it's just kind of thinking about that. So back to this. So direct primary care provider will not bill third parties or on a fee for service basis. So we do not accept insurance. I don't bill insurance. I don't want to deal with insurance because I don't want insurance telling me what's best for my patients or how to practice medicine. And then any per visit charges under the agreement will be less than the monthly equivalent of the periodic fee. So that's the definition based on the Oklahoma statute. There is a group called the Direct Primary Care Alliance. Is a group of doctors. I wish I could say I was the first one to come up with this, but I'm not. There are about 1,000 practices like this across the country. Again, my buddy Josh, he's been a thought leader and has been doing it in Wichita for 10 years. And he has been on Hannity and Holmes. He's been up at Congress. In fact, him and a couple doctors, Lee Garos out of Florida, Chad Savage out of Michigan, they were there when Trump signed the executive order, right there. So those are the people we have fighting for healthcare. Doctors. So doctors in general want to provide good care. Unfortunately, you're stuck in a system, and you do what you have to do within the system to make a paycheck, right? You jump through all the hoops that you have to. And to be quite honest, it's quite gutsy to go out and do something like this. You know, you risk a lot, and not a lot of people are cut up to do that. So a lot of people like other people to be the guinea pigs, and then when it goes okay, then they're like, hey, are you hired? So direct primary care, very simple. It's a relationship between the physician and the patient with the absence of third party, okay? It's direct transaction. You pay me, I take care of you, period, that's it. Nobody else needs to be involved.
Question.
Yes, sir.
How do you interact with the hospital if you want surgery?
That's a little bit different. That would probably be the instance that you need to have insurance, honestly, unless there is so we're members of the Free Market Medical Association, started in Oklahoma City by Keith Smith, who is a anesthesiologist, and Jay Kempton, who is a third-party administrator, actually. So they started the Free Market Medical Association, and Surgery Center of Oklahoma does some cash pricing. You can literally go on their website and say, oh, I need a knee replacement. And you can click on the knee, and it'll tell you what the cost is, boom, up front. And I've seen him talk at least once, and he talked about a lady, I believe, that was out of maybe Puerto Rico or the Dominican Republic, diagnosed with thyroid cancer, and it was going to cost in that country like $200,000 for surgery. So they called him and said, hey, what's it cost for thyroid surgery? And I think it was like $2,500 or $3,000. And he said, we're willing to do it, but she needs to have a primary care doctor that can follow her for 6 months. And as long as we can make sure everything's okay, then she can go back to Puerto Rico. And so they said, okay, we'll do it. So they flew her to Florida, put her up in a hotel for 6 months, paid for her to fly to Oklahoma, have surgery, fly back to Florida, and then paid the direct primary care doctor to take care of her, paid for her medication. Total cost $10,000.
So is that who you're affiliated with then?
We're not really affiliated with anybody, to be quite honest. We don't do affiliations because usually what happens in any type of contractual stuff, they want you to send everybody their way, right? I'll do that if the price is better and my patients are going to get taken care of. I just want the best price. Like I have contracts with 2 different lab companies here in town. I can tell you one is about half price the other one. So why would I send you to the other one? Why would I send you to DLO when I can get it half price for LabCorp for the same lab? So we do make associations and talk to other people. Like we just talked to an optometrist yesterday. For his assessment, he usually charges $99. For our patients, he's going to charge $74. So we'll save you 25% right there. So we kind of we're constantly trying to negotiate. I will tell you in Tulsa, it's a little bit hard because you have 3 hospital systems, really 2 big ones, and 2 that own an insurance company, okay? So that's the hard part here. If you start looking at subspecialists like cardiologists, you're going to be hard-pressed to find a cardiologist that's not associated with a group, okay? So those are some limitations currently. And some of the other...
There is one. Dr. Higgins, James Higgins.
All right, I'm going to have to remember that. I'm going to reach out to anybody I can because, I mean, our purpose is to try to save people money and get them good care. And as long as the physicians, and I think every physician goes to medical school and they want to really take good care of people, but then they get in this system that's just broken, and it really makes it difficult to take care of people. And so if I know that somebody is going to take good care of my patient, and they're willing to negotiate, they may say, hey, this is my price, and it is what it is, because we try to negotiate with the imaging facilities. I try to get them to get lower, because I know that Lee Gross can get an MRI for $279 in Florida, and you would think that the cost of healthcare in Florida would be more expensive than Oklahoma, right? So I said, hey, let's try to negotiate and see if we can bring this down. And they said, no, our price is $375. And they started throwing out all these, there's a anti-kickback law and all these things. And I said, well, I'm not getting a kickback. I'm just trying to get a good price for my patient. That's it.
I want to say one other thing about, you're talking about the system. People often ask, why don't doctors fight Medicare. Why did they take this? Why did they take this abuse? Well, in 2000, and I haven't checked lately, but in 2000, Medicare had 100,000 pages of regulations. There is no doctor on earth
Yeah, we don't have that
that
much
is
time.
totally in compliance with 100,000 pages of regulations. And doctors are scared to death of being audited because they know none of them will pass muster. If the government wants to kill you financially or ruin your practice, trust me, they'll find a way. And this is the source of a lot of the abuse that we're now seeing in the government, is all these regulations.
I mean, Medicare, if you look at what they reimburse, like per patient, is actually probably the lowest along with Medicaid. But if you look at total dollars, they're the largest payer. And so if you look at, any hospital system or whatnot, they're never going to say, let's get rid of Medicare, because that's their money. That's the largest portion, percentage-wise, of their income. They're not going to get rid of that. And it was there was a doctor when I was going through training. He used to always say, if it's good enough for Medicare, it's good enough for everybody else. And if Medicare passes it or changes anything, the private insurance companies are not too far behind. They're going to start changing the way they reimburse. Now, most of them, Blue Cross Blue Shield, they may reimburse anywhere from 110% to 170% of what Medicare will reimburse. But Medicare is kind of the bottom. And so when I try to negotiate, I'm like, hey, how about Medicare plus 10%? And most people are like, no. Some people, and I'm starting to see a trend. There's starting to be providers out there that are just going to cash pricing, because it just makes more sense for us and for the patient, to be quite honest. But
Hi, thank you very much for doing this, and I'm glad that Rhonda invited you to speak. When I was studying healthcare, the interest in it was the data sharing and the development of electronic health records and the sharing, and which of course gets to be global sharing. What are your issues on your policies on privacy and the records that are created on the patient's visits?
so in our particular clinic, to my knowledge, there's no law that says I have to share my records with anybody. Because since I don't accept Medicare dollars in my clinic, then I'm not necessarily bound by Medicare regulations for that. But we still try to maintain HIPAA compliance. So we have a communication app that is HIPAA compliant. Like I've had, and this is again a group of people across the country that are doing it. Some of them are not submitting records unless the patient actually requests it. And that does potentially create a conundrum when it comes to people trying to sign up for insurance, because insurance automatically assumes that you have the worst of the worst, right? So they're going to try to give you the highest rate that they can if you don't give them any information. So you're a little hamstrung to a certain extent, but I'm not really required by law to actually share
So if
information.
the patient asks you for privacy and that the records stay with you, you would offer that?
Yeah, as long as, did you say you couldn't hear?
The issue, the question has to do with patient privacy and the interaction between you and your doctor. The way it's set up right now, especially if they're using the Epic system, everything is recorded. Peggy knows about the International Classification of Diseases. So if you mention that you're depressed, that goes on your record, and then of course, then if they do a background check, you could maybe not get a gun. There's all kinds of things that the system, the Leviathan that you showed, which are actually anti-patient.
Hillcrest and St. Francis are on the Epic system. I'm not sure
Right.
about St. John.
St.
Yeah.
John uses Cerner.
Yeah,
It's all on Cerner.
Yeah.
Cerner.
All
So,
that information goes into a central database in Belgium, right?
It
Well,
is-
and
it's an international classification. All of the electronic records have to comply with the ICD-10.
right.
And they are shareable, except with your husband or your wife, because of course they can't access it.
Right. Absolutely.
Yeah.
Everybody else can know, but not your
Everybody
significant
in
other.
the world can know it, but you know the one you want to know it. Okay, and then the other thing is we're very glad you're associated or want to be associated with Dr. Smith at the Oklahoma Surgery Center, because they're the flagship is like, this is the way you really should be able to do it.
Yeah,
on-
they're
I
the
wasn't-
flagship in the country, really.
I wasn't clear, is this in addition to insurance? His question about, let's say you're in a car wreck and you need surgery, is that, you still maintain insurance?
Yeah, absolutely. But again, it goes. If you go back to that slide of the $18,000 versus a couple $1,000s, it's utilizing the way you spend your own money. Okay, so in general, on average, only 5% of people will ever use a $5,000 deductible per year. Okay, so 1 in 20. Now, if you're one of those people that has chronic medical problems, you end up in the hospital year after year, you definitely need insurance, okay? But if you're somebody that doesn't require a lot of that stuff, you could actually switch to something of a higher deductible plan. And the money you save on premiums, you could save up to $10,000 a year. And if you don't ever hit a deductible in 10 years, that's $100,000. But I don't know about you, but I can do a lot with $100,000.
We used to do catastrophic, and then my husband would negotiate too.
Right. So our model is you actually pair it with something, and direct primary care is actually recognized even via the Affordable Care Act as long as it has an appropriate wraparound plan through them. But I mean, I say through them. It covers all of the bases that the Affordable Care Act wants insurance to cover, essentially. So basically, what direct primary care does, we cut out the middleman, and then if you watch this this doctor's head here. Oh man, look where he's looking now. So patient pays doctor, doctor takes care of patient. It's that simple. And so instead of that other, where the doctor or the patient was over here, you had the insurance guy in the middle, and then the doctor over here. Now it's the patient, the doctor, and the doctor's the quarterback. Hey, what medication do you need? Do we need to do lab? Do we need to send you to a specialist? And then we're really in control of making that decision. And we want it to be a mutual decision. It's not a dictatorship. It's not, hey, this is what you need. It's, hey, this is what I recommend. What are your thoughts? Do you want to try something alternative? Whatever it may be. So when we start looking at the benefits of direct primary care, first thing, no scheduling fees or copays, okay? So somebody can pay me our monthly fee. You can come to my office 1 time, 0 times, 5 times. It doesn't cost you any extra money, okay? Monthly billing and no long-term commitments. We're pretty confident in what we do. I don't need to have somebody locked in for a year, okay? We want it to be a long-term relationship because when I assume care of a patient, I assume I'm going to take care of them for the rest of their life. And if they leave, that's okay. They can go seek out the other stuff. But about 90+% will come back. Because they get a taste of everything else, and they're like, this tastes all too familiar, and I don't like it. Our appointment times are extended, so it's not uncommon for us to spend 30 to 60 minutes with a patient. Sometimes new patient visits, they can last a while. Dr. Suddath just spent 4 hours with somebody today. We dig deep. We start digging into a bunch of stuff because, again, there are so many things that determine your health, which I'll talk about on the next slide. And that will hopefully kind of hit home kind of what we do. Typically, we can do same or next day appointments, which is also a benefit. 24/7 access. So I mentioned we have that HIPAA compliant communication app. So you can call us, text us, email us anytime, after hours. We usually respond fairly quickly. If you email me, it's probably not going to be for 24 hours because I don't have push notifications for a reason. But text messages, those sorts of things, we usually respond to pretty quick. And it may be, hey, I have, these are the symptoms I'm having. One of the fallacies of primary care in particular, about 60% of office visits are unnecessary. It means a lot of this stuff can be handled over the telephone, but you have to remember how physicians get paid. They have to have you come in the office so they can create a billable claim for insurance, right? That's how they get paid. Since we don't deal that way, I don't have to. Somebody wants to text me a rash, and I say, oh yeah, I think it's this. Where do you want your script called in? You want to stop by the office and pick up some medicine? It really is that simple. We do house calls if warranted. I don't advertise that in general because I can't drive all over Tulsa all the time. And then, of course, we do after-hours visits. Some places add an additional fee. We currently don't. That may be something that happens later on. but we don't do that. So I've met a patient, oh, let's see here. He started texting me about 4:30 in the morning on Bedlam football. And I have season tickets. And I was thinking, oh, crap. So this is how this is going to go, huh? So we texted for about an hour, and I said, all right, that's enough texting. Can you meet me at the office at 7 a.m.? And it was Saturday. He said, I can do that. So I told my wife, hey, you load up. I'm going to go to the office, and I'm going to see this patient, and you just roll on by, and I'm going to jump in the vehicle, and we're going to head to Norman. So I went and saw him on Saturday morning and took care of him. And, it was a good experience for him. Good experience for me, too. But those are the kind of things that we try to do, too. Access to your medical records. So after our visits, we actually, in our record, we use Elation, which is actually designed for direct primary care. We actually type up a care plan, and we send it to you through that communication app. So you know exactly what I'm thinking. I put down your diagnoses. I put down what the plan is. That way you know. Again, you guys are supposed to be involved. You guys are supposed to know and understand what's going on. Because if you're not an advocate for yourself, nobody is.
That's right.
Okay? You have to know your health conditions. You need to know what medications you take, why you take them, all of those things. Very important. So we have access, and then we even have a little portal that we can give you access to, and you can have access to our records online. This says free diagnostic testing and lab work drawn on site. That's not true for our clinic. LabCorp, the contract we have with LabCorp, they charge us $0 to draw people's lab. So I don't have to pay somebody to be in my office to draw a lab. Typically, if you use your insurance, there's always a $25 fee for vein access or venipuncture or whatever. So your insurance pays for it, right? They don't charge us. So, and we just try to pass costs on to our patients. We cover our overhead costs because we get charged a little credit card fee or whatever. But, and then of course the diagnostics, we don't have any imaging on site, but again, there are companies around here that are doing it. There's no reason for me to invest a ton of money in stuff and inflate the cost when I don't have to. Somebody else has already done that. I'll let them take care of it.
But you do find suppliers, so you can direct people to other suppliers.
Oh yeah, I can tell you I can get medication. We have a patient that has a port and gets IV fluids 3 days a week. We basically showed her how to do it. We purchased the supplies for her, give them to her, and she does it at home.
Okay. But what I'm saying is, you already have scoped out some external suppliers, so that if a person comes to you and needs an X-ray or something, we don't have to go shopping ourselves. You can say, well,
Nope.
we got this guy here, and he's got a pretty good rate. And,
Yeah. Servant imaging, it's now Touchstone. Envision imaging, Advantage 3T MRI at 91st and Yale. The prices vary depending on what you want, but X-rays are $67 to $70. So part of it, I look at where people live and what's convenient for them, or if they have a preference. I personally don't have a preference. MRIs you can get for $375 to $400 if it's without contrast. CT scans are around $250. So we already have made and established those relationships. Yeah. Medications dispensed in our clinic at wholesale prices. So we actually use a wholesaler out of Florida, and if I order medication before 6 p.m., I have it in my office by 10 a.m. the next morning.
Oh, wow.
We have stuff on site, and I'll show some prices here in a little bit. We talked about the discounted prices. This is, again, looking at determinants of health. This graph is actually a little bit old. So it says individual behavior or lifestyle choices is 40%. It's actually more about like 50%. Here it says genetics is 30%. It's actually about 20. Then this has social and environmental, 15 and 5. We just add it and say 20. So basically we have 50, 20, 20. And then what we do in healthcare, 10%. The smallest piece of the pie, that's what we do. So actually if we focus on the preventative stuff, we can save a lot of money. And so that's what we try to focus on in our clinic. And, we try to motivate people and try to get them to change and those sorts of things. This is just reiterating house calls. This is Dr. Sudeth, my partner. He had a patient, kind of working poor, can't afford to miss work. had an eye problem. He said, hey, just take a picture of it, send it to me. Took a picture. He said, I think I know what's going on. Ran to the clinic, got medicine, went and met him at work, and called him, said, hey, I'm down here in the truck. The white truck with the Remedy magnet on the side. So patient came down.
That's where you're going to get your reputation.
So it's him, not me. No. So patient came down, got in the truck. Dr. Seth brought his supplies to just do a quick exam. Said, yeah, this is what you have. Here's your prescription. It's $3.83. Go back to work. It took him 5 minutes. So for, in particular, employers, you know, you don't want people missing work. That costs money. And in the typical system, it's you have to take off a half day of work, you know. You go to the doctor's office, you fill out all their paperwork, you sit down, you wait for 45 minutes, they take you back, do your vital signs, put you in a room, you wait another 15 minutes, and then the doctor comes in and spends a whopping, on average, 7.7 minutes with you. And then OTD you go, all right? So, yeah, out the door. So this is a picture of us in our pharmacy. So we've got, basically where we save the most money is generic medication. If it's a brand name, I can get it, but it's a brand name price for me too. You know, EpiPens are still $300.
That's crazy.
It is crazy. Now I haven't figured this one out yet. I need to talk to him, but I know that there are at least 2 direct primary care doctors, actually both in the state of Kansas, who have figured out how to make an EpiPen for their patients for about $25. So this is the kind of innovation we have. We have doctors saying, what in the heck is going on here? Like, we have to figure out a way. And so this is some medications here. This is just typical, some suggested pricing, I guess. So if you were to go pay cash for Augmentin, it is actually on the $4 list at Walmart. But it's $101. It's $6.60 at our clinic. The infamous Z-Pack, it cures everything. From what I hear. So retail price, if you pay cash, is $46.70, and it's a whopping $2.50 in our clinic. Cymbalta, it's typically used for depression, fibromyalgia, neuropathy. You know, it's $235 cash price. We get it for $4.62. Crazy.
Is that for a 30-day supply or?
Yes. Yeah. And we have our prices on our website. Gabapentin, again, used for neuropathy, typical of diabetics. This medication is actually, and of course our prices are subject to change because it's based on our supplier. We try to get it as close to cost for our patients. You know, we have a very, very, very small margin, but not anything, it's not a revenue stream for us. That's not what I want it to be. My whole purpose is to reduce the entire cost of healthcare. That way, everybody benefits. Viagra. Maybe people use that. It's about $13 a tablet, but we can get it for about $1 a tablet. So if that doesn't get you excited, I don't know what does. Sorry, pun intended. So savings on blood work. A typical, just checking your cholesterol, $62.50. I can get it for $3.05. Complete blood count, that's looking at your white blood cells, hemoglobin, platelet count. $30, I can get it for $2.50.
Those are good prices. I can attest to that.
A hemoglobin A1C, if you're a diabetic, $45, we can get it for $2.78. I mean, it's just silly how much money you can save.
Do you guys see why I got so excited when I came across these guys?
So this is just talking about, this is just kind of comparing direct primary care to kind of what typical expenses are for people every month. So auto insurance, $82, I wish. Mine's more than that. And I don't drive anything nice. Cell phone bill, $102. Yeah, mine's about $200 with my family. Cable bill, $123. Yeah, mine's like $210. So a typical, if you look at direct primary care across the country, on average, close to about $135 a month. And yeah, not at Remedy. So for adults, it's $65 a month. Again, no copays. So this is our pricing. So for adults, $65 a month. If you're with the parent and you're 19 years or younger, it's $25. If you don't have a parent, we charge you the adult price. And then we set a cap on families. So basically, if you have 2 kids, you're already saving $5 a month. If you have 3 kids, that third kid's free, and so is the fourth, and so is the fifth, and so is the sixth. We have some of those. We love them.
I am one of those.
So, for people that might own a business, we actually knock about $5 off of each for them, and that's because they usually bring us more people at one time. So, by default, they should get a discount, at least as far as I'm concerned. One of the things that we used to talk about, at least for business owners, if you owned a business and you purchased insurance, you had what was called fully insured, meaning you paid Blue Cross Blue Shield or CommuniCare or whatever, your premium, and you had the plan where you went and paid your copay and you had your deductible and all those things, and nothing, the insurance company couldn't charge the company any more money, right? Well, there is a thing for small businesses, as long as you have less than 50 full-time equivalents and over 5 or more. You can do what's called partially self-funded, where basically your money goes into 3 pots. You have the plan administration. You're not ever going to see that money again. You have stop-loss insurance, which is insurance for your insurance. So, because the business is assuming a little bit of risk. So basically, you set the cap. As a business, we're not willing to spend more than X number of dollars, and then you have a stop-loss insurance to cover that. And then you have your claims account, which is where all the claims come out of. Well, the benefit to us, and my buddy Josh, who's been doing this in Wichita, he has several businesses that have signed up with him. And what happens is when you're using direct primary care, since we don't bill insurance, there are no claims submitted, right? So when you come see me in the office, I'm not submitting any claims to insurance. So there's no money coming out of your claims pool. If you get medication out of my pharmacy, still no claim. And if you go to Walgreens or CVS, you will. Labs, if you're paying cash for it, still not coming out of your claims pool. So you can see over time, that money stays in your claims pool. So in this particular instance, at the end of the year, if there's money left in the claims pool, business gets that money back. And what that does is the insurance company says, well, man, I gave you $10,000 back this year. So we're going to decrease your premium. So my buddy that's been doing this in Wichita has, with his businesses that have done this, he has yet to see an insurance premium go up using that plan. And we actually just recently, we use a guy out of Wichita. He works with about 8 direct primary care clinics doing insurance and coming up with some ways to kind of finagle around the system to get coverage for people. But we also just recently met a guy locally that also does that. So we're excited, and he's quoted some patients, and the prices are pretty deadgum good.
The state of Oklahoma made a deal with the hospital, Oklahoma Surgical Center in Oklahoma City, because their prices were so low.
Mm-hmm.
They made a deal to encourage state employees to use the surgery center instead of regular.
I'm just telling you, I see so
Yeah.
many possibilities.
I mean, there's different stuff like MediShare. It's one of those health sharing ministries. They have a contract with St. Anthony's. Basically, if you have MediShare and you need a bypass surgery, St. Anthony says it's $35,000. MediShare says I'll pay for it all. Nothing comes out of your pocket because of the amount of money that they save by using the free market approach. And so that's the whole system, and I think it's growing. Oklahoma City is a little bit more progressive than Tulsa because they don't have really systems that kind of control what happens. But I think it's growing. There's going to be hopefully people demanding that this is what they want, and this is the way for us to save healthcare and save taxpayers money, right? Everybody has a handout, and we just need to limit how many hands are out.
Can we start asking questions?
Absolutely.
'Cause I've had a couple of questions brought to me. Do you guys support natural health? Like
In what sense?
Like
naturopathic medicine, like herbal supplements. Mm-hmm. So there's actually a study that just came out within the last week that says there are no benefits from an all-cause mortality or cardiovascular standpoint for supplements. Okay. Now, if people want to go spend money and it makes them feel better, I'm not opposed to that. There may be a placebo effect. There may be a real effect. But we're very open-minded about stuff. I'm not going to tell somebody that something's voodoo. I mean, if they think that it's beneficial, we try to use evidence-based medicine. you can always call things into question, because then the question is, well, who's doing the study? Who's paying for the study?
Right.
Who stands to gain something out of it, right?
Okay.
So, to answer your question,
What about vision and dental? Do you guys have any connections on that?
so vision, I mentioned the optometrist. So his eye exam is $74. When it comes to dental, Dr. Calhoun, he's in Bixby. He will do a, first exam, x-rays, cleaning for $60
Oh, wow.
cash. So we are constantly trying to make connections with people because we know that that's what people want. And honestly, from a government standpoint, if a patient or a person, individual is willing to take money out of their pocket and pay for something, then why bear the brunt or the risk of it? Doesn't make any sense.
So if somebody comes in and you find out that they've got some catastrophic illness, what do you do? Do you refer them to St. Francis, or what do you do?
So
You can't do it. It's beyond your primary care.
the short answer is I don't care where the patient goes. I don't care if it's Hillcrest. I don't care if it's St. Francis. I don't care if it's St. John. If they have an established relationship with one of those systems and they want to go to a particular system, then we'll find somebody that will take care of them. And we try to do the legwork for that. Unless sometimes I say, hey, you have friends, go ask your friends.
You know, what if they don't have any other insurance except yours?
Well, we're not insurance, first of all. Let me
Right,
clarify that.
but
we are not insurance.
Have dropped their insurance because they're using you.
I would never tell anybody to drop their insurance.
But that's it. This isn't to replace insurance. This is to reduce our cost of our primary care so that we can get catastrophic insurance and not pay thousands of dollars a
Right.
month for it.
So,
So what
instead of
us
paying,
seniors do, we have to get Medicare and all that.
well, I will tell you that is the one population we cannot take care of at this time, and part of it is political. So Medicare,
That's not true.
no, it is true. Give me a second. You're not letting me talk.
Hang on.
So, if you work in a hospital system, which me and Dr. Suddath do still currently, okay? If you work in an insurance and you accept Medicare, which you have to by default when you work for a system, then it is illegal to directly contract with a Medicare patient in our clinic. The only way that we can do that, well, there's two ways. One way is we have to opt out of Medicare, but if we opt out of Medicare, then we can no longer do our current job, okay, which pays our bills because we're still growing. Or there is some legislation that they're trying to pass, and I don't know exactly where it is in that process, but they're actually trying to make it legal where physicians can directly contract with Medicare patients, but that has not made it anywhere yet. So that's the limitation. Or if a hospital system's nice enough for you to work for the hospital and they say we bill as the group, or they have a medical director that you bill under, and you didn't sign anything, then you can get away with it that way. And that's actually kind of a fine line, but that's the limitation.
Okay, here's what I would tell you. A Medicare patient can have any service he wishes, whether it's covered by Medicare or not, and he agrees to pay for it. He signs an advanced beneficiary notice, which is a Medicare form. And in that notice, he says, I understand that Medicare is not going to pay for this service, and I have agreed to pay for this service directly myself.
You can only do that if you're opted out of Medicare, though.
That's not true.
That is true. We have a legal. Well, there's 1,000 doctors across the country doing this, and we have legal representation, and that is the case. Otherwise, we would be doing it.
They've recently changed the law because it didn't used to be true.
You can now, so that is something that we have to do once we opt out of Medicare and we can accept Medicare patients. Then we have the patient sign something saying, you are not going to seek reimbursement from Medicare for services I render, and I'm not going to try to seek reimbursement from Medicare. That is true.
So now, so I think maybe what it is it's not so much what she can do, but what you're limited to by the way that you're structured at this time. Is that correct?
Well, the contract that you sign anytime you work for a system, so the same goes for Blue Cross Blue Shield. it's Blue Cross Blue Shield, it's all the private insurance companies. Because basically, if you sign a contract with an insurance company, they're saying, well, anybody that's on this plan, anybody that has Medicare, anybody that has Blue Cross Blue Shield, well, you're basically saying that they can come to you because you're accepting that insurance. Right? And you're going to accept the rate that we're willing to pay.
Gotcha.
Correct? So they're not going to allow you to directly contract with the patient because that undermines what they're doing. Okay?
Taking them out of the process. Gotcha.
Correct. So we have to opt out. So even you have to say, I'm cutting ties with Blue Cross Blue Shield, I'm cutting ties with Community Care, I'm cutting ties with everybody out there so I can bill directly.
Okay.
And so we can't do that with Medicare yet, but we're hoping that we can soon.
Okay.
Are you the only facility in Tulsa Metro?
There are, let's see here, we're the third clinic actually. So one of the things I did not mention, one of the ways that we are able to do what we do, spend time with patients, we actually limit our patient panel size. So we only take about 800 patients per physician. If you look at traditional primary care, it's around 2,500 to as high as 6,000 patients. So we're taking a significantly less number, so we're able to do and be involved a little bit more. And so the next question I'm sure that will come up is, well, there's a primary care shortage. How are we going to do that if you're only taking 800, right? That's always the next question. And really with this model, it's liberating for patients because they're actually getting the care that they need. I have yet to figure out how you take good care of somebody in 7.7 minutes. Haven't figured it out yet. And the other thing is it's liberating for us. It's liberating so I can have a direct relationship with the patient and I don't have to worry about someone else telling me what's best for them or me or my practice. So if we can actually make primary care more appealing, you're going to get an influx of primary care providers. So they have to change the way that they reimburse stuff. I mean, primary care providers get reimbursed less than anybody. Pediatricians maybe get less than them, which is still primary care. But when you look at insurance reimbursement, you get what you incentivize, right? If you incentivize paying more to subspecialists, guess what the people going to medical school are going to do? They're going to go into a subspecialty. And now you get rid of your primary care doctors, and now you're replacing them with, alternative people to provide care because there's a shortage that you always hear about. There's always a shortage in places, but most people don't ever go to these places unless they grew up there. We pass all these bills to give, nurse practitioners, PAs, et cetera, expand their scope of practice so they can go to these rural communities. But there's not been one rural place in Oklahoma that's actually been filled and closed that gap by them. They want to stay in the metro just like everybody else.
That's not true.
Huh?
That's not true. I'm sorry, I know nurse practitioners who are begging to have doctors who will be able to oversee their prescriptive authority because of the fact that the doctors won't go to the rural areas. And they can't find one soul who will oversee their prescriptive authority because it's because of the law. So if we give them freedom, there are nurse practitioners who will go to the rural areas. And I know some of them personally.
Okay.
It's a rough crowd.
Hey, that's all right.
Yeah, we are.
I have semi-broad shoulders.
It's all good. But no, that's one of the things that we're about. We're about having conversations so that we can explore other avenues. Free market is what we want.
Absolutely.
When they talk about healthcare and healthcare reform, it's not healthcare reform. It's insurance. They're not talking about healthcare because this, you just showed us right here, this is affordable. This is affordable. People can afford to pay that in a month to be able to have access to a doctor that we can call you, we can Skype. I mean, it said we can Skype. Mm-hmm. You can, there's so many things that we don't have to go to the emergency room to get stitches in our head. We can come and see you. And so I think that the service that you guys are offering is great. I think it's a great idea as far as a free market principle and method of being able to have our healthcare taken care of.
Yeah, and I think that will continue to grow again. I think we'll start to see subspecialists do it. I mean, there was a chiropractor that came by our office that said, I do $25 office visits. I've been a chiropractor for 30 years and I'm tired of dealing with all this crap. Said, well, $25, that's actually the cheapest I've seen around here.
Yeah.
You see some people who do 40 or 45, 50. 50 is about the going rate. There's some physical therapists that will do stuff, and their prices range anywhere from $75 to $150 an hour. So there are people that are actually starting to offer cash prices in a lot of different specialties and even, ancillary services.
Right.
So I think it's going to be something that's going to be growing and ultimately trying to get out of, again, the insurance model. We should use insurance appropriately. It serves a purpose.
Mm-hmm.
I mean, we just need to utilize it differently. We don't need to insure primary care.
No.
You can make it way more affordable.
Does anybody have any more questions?
I don't think I completely answered his question, though.
Okay, go ahead.
So we were the third. There have been, there's like six probably in the Tulsa area. One thing I would tell people to watch out for, since it is kind of a newer thing, anytime you have a fad, I say a fad, something that's growing, there are always people that want to start doing stuff to take advantage of it.
Right.
And then they start offering different things that are always additional costs. So I always tell people just to be wary of what you're looking at, what you're signing up for, and what they're trying to sell. I don't have any products in my clinic as far as I'm not trying to sell vitamins, I'm not trying to sell supplements, I'm not trying to sell CBD oil, I'm not trying to sell any of that stuff, okay? Is there a purpose for that? Are there some people that get benefit from it? Absolutely. But that's not anything I'm trying to push or sell that's gonna make me money. So I always tell people to watch out for that. If people are selling product out of their office, they're making a profit on it.
I would also say this, the fact that you have 2 physicians is good because then somebody is probably always available to take a call. If you had only 1 physician in your practice, you'd be insane. I mean, you couldn't keep up with the work.
Yeah, we actually have, so we've talked to some people that we worked with over time, and again, they don't want to stick their neck out there and get it chopped off. But we have people that are willing and ready to join whenever we're ready from a business standpoint to bring them on. We know one of the questions we always get, well, do you have a female? No, we don't. But the next hire will be a female, I can guarantee you that. So, because we get that question a lot, but
But do
yeah.
you cover like gynecological? Thank you, I couldn't gynecological.
Yeah, the only additional cost for that is what the pap smear costs, and it's $22.85 for them to actually run the pap smear. If it is positive and they reflexively check it for human papillomavirus, it's $68.25 or something like that. So I tell people the cost up front. This is what it is if everything's normal. This is what it is if it's abnormal.
And then I'm going to ask about networks, and because like let's say that I'm away somewhere and I have need of a primary care physician. Is there a network that we can tap into?
So as I said, there's that Direct Primary Care Alliance. So I'll just use an example of a patient. We had a patient that does jujitsu, and it was down in Florida, and hurt their ankle. So they contacted our office, and Dr. Sutta said, I think I might know somebody. So we went on the Direct Primary Care Network, found a provider in Florida, and called them and said, hey, we have a patient that's down there. Can you see the patient or get him an x-ray or whatever? And they said, oh, absolutely, we can do it. So they saw the patient, got him an x-ray. The x-ray actually was cheaper than what it costs here in Oklahoma, sad to say. But she was able to get all that stuff done in Florida and be taken care of while she was gone. And then we just reassumed care when she came back. They didn't charge her anything. And so there's a group of us that, if anybody from anywhere else comes here and they want to see us because they're out of town and, they don't have access to their doctor, then I will see them and I'm not going to charge them. They already have a membership fee with someone else. And that's just what you do.
Right.
That's the right thing to do.
You're right. You're exactly right.
That's how you make the world go round, right?
That's exactly right.
So.
Anything else you want to add to this? How do we reach you?
I have cards, so our website is www.remedyhealthdpc for directprimarycare.com. Let's see here. Main office number is 918-884-7699.
And I did put a link in the email that I sent today as a reminder. I did put a link to their website, so you can get to that if you don't remember the web address.
We have our email It's very simple. DR, like doctor, no period, street, S-T-R-E-T, at remedyhealthdpc.com. And Dr. Sudduth is the same. It's DR, S-U-D-D-U-T-H, at remedyhealth.com. So you can email us. We can get people that call us and ask us questions about stuff all the time. Because they really want to know.
They respond on Facebook too.
They want to know what that's true. Sometimes not as fast, but no, but we want to be very open and honest about stuff. There's no reason to try to pull the wool over anybody's eyes. Let's just be open, transparent, honest, and any questions that come along, we're more than happy to answer.
You may have answered this, but I don't remember. Do you have a panel size you're looking for? How many patients you want to take?
Yeah, we limit ourselves to 800 per physician. So it is, but that's what allows this model to work. Because you have to think about it. The more patients you have, the more people you have coming in your office, which means the less amount of time you have to spend with them. And so people also ask us, well, why do you have just a membership fee? Why don't you just do fee for service? Again, you get what you incentivize. Yeah. So we tell people that we're concierge, but affordable concierge. Okay?
Motel 6.
We'll leave the light on for you. I'm Tom Bodine or whatever his name is.
That's right.
Dr. Calhoun is the dentist, and I am blanking on the optometrist name, but I'll get it for you. I'll give you my card, and then you can shoot me an email, and I will. Dr. Sudduth will remember because he remembers names, and he's the one that talked to him personally. So I'll talk to him, and I'll get it to you. You're welcome.
Does anybody have any questions? Any more questions? Oh, here we go.
800 limit already, or?
No, not currently. Not currently. We have a little ways to go, but that's also why we still work in a hospital system. As I stated before, the clinic is not bringing income.
So, yeah, bringing enough income.
Into my home, not enough to supplement or take over for what we were doing, or to make it feasible. So that's part of the reason we have two doctors. So we actually alternate working in the clinic and in the hospital. So I'm in the hospital this week. He's in the clinic this week. There's times that we're there together, but usually it would be like late afternoon. But we did that. We went into it together with that purpose and that design in mind. Of course, hospital systems don't like it. Hospital systems say, hey, you're doing this. They perceive us as competition to their primary care providers. And so they've told us as much and have also said, hey, you might lose your job. It has to go to legal, whatever. But that's one of those things that, it was a risk that we were willing to take. It may not be easy, but it makes sense.
How long have you been doing this?
Like being a doctor or just the clinic?
No, in this practice.
So the clinic has been open since September of 2018. So coming up on a year. Yeah. Yeah, and that's about right. 2 to 3 years. That's we projected about 2.5 based on our projections. So. Yep.
Well, I can't tell you how thrilled I am that I've found you on Facebook and your business, because, like I say, I think it's a great answer to a question when people say, talk about needing affordable health care. I think you guys make it more than affordable.
Yeah, and if there's anybody out there that knows anybody, again, I don't care if you have insurance, if you don't have insurance, I don't care about race, I don't care about anything. I just want to take care of people.
That's the way doctors are supposed to be. Thank you.
No, thank you.
We
Thank you.
appreciate it
No, thank
very
you guys. I
much.
appreciate it.